Purani, please.
I'm thankful to Dr. K.K. Agrawal and eMedi News for giving me this opportunity. Similar to the cardiac branch, the hematology also has significant move from, there's a lot of work is happening in the bench and is translating on the bedside. I'm just going to compare it then and now. I think the journey started here. There is a new ammunition in the war against cancer. The Gleevec was born in 2001. We know the disease chronic myeloid leukemia. Previously, we were using hydroxyurea, busulfan, and curing few patients with a bone marrow transplant. We had an oral drug which was a targeted therapy, was targeting the molecular defect, and it changed the overall treatment of chronic myeloid leukemia. So first is a chronic myeloid leukemia. As I suggested, we had a few options. Now we don't have a one targeted therapy in chronic myeloid leukemia. We have a 3 targeted therapies. So if one drug doesn't work, we have two more options. So they all are oral therapy. Rather than if a patient with a CML comes to the hospital, they come in a panic, and then you say you have a medicine and go home, you will survive for many years. The people don't accept easily. It becomes initially unpalatable. So what this drug does, we know this is a BCR-ABL defect, which is a cause of chronic myeloid leukemia. Is a ATP binding. It leads to the phosphorylation of tyrosine, and that leads to the chronic myeloid leukemia. This is a molecular cause for chronic myeloid leukemia. What does the Gleevec does? This blocks this ATP binding site. So there is no ATP, there is no phosphate, and there is no phosphorylation of tyrosine, and there is a blockage of the molecular pathways which leads to the increased proliferation in chronic myeloid leukemia. So we have targeted the molecular defect, and that journey started in roughly around 2000 with the chronic myeloid leukemia. With Gleevec, we got these kinds of results. 98% hematological responses. We were not talking about the hematological responses. We were talking about the cytogenetic responses. We were not talking about the cytogenetic responses. We are talking about the molecular responses. Till now, we were talking about achieving some target. Now, the second line generation like dasatinib and nilotinib has been approved upfront over Gleevec. Now we are talking about complete molecular responses. And the people who have achieved the complete molecular responses, trials are going on. If you have a complete molecular responses for 2 years, you can stop the medicine, and some of the patients can be cured, not need to take a medicine for longer. So we are not seeing only a hematological responses. We are going down in the depth and looking for a chronic complete molecular responses. These are the 2 new medicines, which are nilotinib and dasatinib. They are more potent and more effective in comparison to imatinib. Has been FDA approved for upfront use. What we gained in the last few years, we had 3 TKIs. What we lost, a transplant. These all drugs are costly. People are not able to take it for many years. There are few patients who go into the blast crisis and we lose them. Now the curative option, which was a transplant, the lesser the people are accepting, the people are not ready to go for the transplant. We lose the many patients because they don't accept it. I'll move to lymphoma. Previously, the treatment, if it's a Hodgkin's lymphoma, was ABVD and non-Hodgkin's lymphoma CHOP. Now we have a monoclonal antibodies. We know that the cell has antigen. We can target some cell, and we have one drug is called rituximab, which has been combined with all the medicines. So all the chemotherapies have been combined with the immunotherapy. So we don't have only the chemo. There is an immunochemotherapy. So we are having a more targeted therapy in lymphoma also. And this is a timeline which shows the more refinement of monoclonal antibodies. It's not only the monoclonal antibodies. Now we have a radiation can be tagged to the monoclonal antibodies, so whether the radiation also can be targeted rather than having a generalized radiation killing every normal cell. We can have a targeted killing by the radiation of the cancer cells. Lymphomas, we are treating more elderly patients. This is data from our hospital. We are treating even up to the 70s and 90s, 70 to 80 years patient, and many of them are getting cured also. I'll move on to the bone marrow transplantation. Previously was only sibling transplant. If you have HLA match, then only you could have a transplant. Now we have more options for the transplant. You can have an unrelated transplant, you can have a cord blood transplant, and now we are talking about the half mesh transplant or haplotransplant. The transplant numbers, the autologous and allogeneics have increased over the years. More indications, more elderly patients also can be transplanted. Think of at 90s and 2000, very few transplants were done in Delhi. Everyone had to go to Vellore for the transplant. Recently, we have completed roughly around 150 transplants in our institute also. So in the last few years, we are also doing in Delhi, not only we, the AIIMS and the Army Hospital also doing many more autologous and allogeneic transplant. I just want to share the one story. There was a young guy with aplastic anemia. There was no HLA-matched siblings, so the transplant was not possible. He was received immunosuppressive therapy with ATG once, no effect. Had a second immunosuppressive therapy given with the ATG. 3 months down the track, he had 2 admissions with the sepsis, was almost dying, and then we decided to do a half-mesh transplant, haplotransplant with his mother. There was only 6 out of 10 antigen match transplant, which was unthinkable previously, and now he's 100 days post-transplant and absolutely well. There are various other diseases. We have a timeline. If you think of a myeloma, we used to treat with the melphalan and prednisolone. Now we don't talk of the melphalan anymore. There are many targeted therapies which don't work only on the plasma cell. They work on the surrounding stromal cells also. So we have a thalidomide, lenalidomide, and Velcade. So we have a more combination. Previously, if you had a melphalan, there was a very minimum CR. Now, if you are using a various combination, majority have a response and many have a CR with the combination of newer drugs. The effect of these drugs, now there is improvement in the overall survival if you compare with the previous years, and major important effect is in the early age group. Most of the patients are early age group. Similarly, in CLL, there is a timeline where previously no one used to talk about the CR. We were using chlorambucil. Now we have a combination chemoimmunotherapy, and there is a 40 to 70% CR rate. So more stronger, more combinations, we are able to achieve differences in the CR. If you see acute lymphoblastic leukemia pediatric age journey, if you were in the 60s and a kid got a leukemia, was almost dying. Now, if you see 90% of the children with acute lymphoblastic lymphoma cured with the combination chemotherapy. We are not improved only in the therapy. We have improved in the classification. We have gone more molecular. Acute myeloid leukemia is not a one disease. If you go by this graph, it has a multiple defects and there are multiple groups. So if you can define this will help you into the prognostication of the disease. That many patients may require a transplant and many patients can be cured with only chemotherapy. So these are the various timelines. The MDS, which used to be deadly disease, only supportive care or allogenic transplant. Now we have many new drugs which are changing the shape of this thing. Other stars in ITP, previously we had a steroid and IVIG. Now we have a thrombomimetic drugs, the oral tablets and the injectable tablets, which can improve the platelet count in ITP. Bone marrow transplant in thalassemia, in 80 to 90% of the patients, if it's class 1 or class 2, if you do a transplant, it can be cured with a transplant. Previously iron chelation was very ineffective. Now we have one effective oral medicine for iron chelation. Similarly, there are many new drugs in the lymphoma, but all is not well. Not everything is well. Still, people need a chemotherapy. It's not only the targeted therapy. Many people are still requiring a chemotherapy. Many drugs, there are a resistance to these magic drugs. All bullets are not without the side effects. People still relapse. And people still die with the cancers. Thank you.
Thank you, Dr. Burani.